Good morning. This is Generosa Grana, and I'm going to be talking about disparities in genetic testing and counseling. I am at MD Anderson Cancer Center at Cooper, and I appreciate the work that I received, the help that I received from Molly Kalinsky with this presentation as we worked on it together. We are going to be focusing on the utility of genetic testing and how it relates to cancer management and risk management, looking at the barriers that have been reported for testing and counseling in minority groups, particularly in the African American population, looking at the prevalence of BRCA1 and 2 mutations in different ethnic populations. This only is an example of the two largest genes that have been studied, but there is much more work that we will deal with. Look at variants of uncertain significance and how the research that's being done in variants of uncertain significance is being limited by minority participation in this work. Look at the frequency of these abnormalities in minority populations, and then really end on a positive note, looking at strategies to increase participation in genetic testing and research, and how there have been successes and how we look forward to that continuing. So how can genetic testing and results be used? They really can and have significant impact on both the cancer patient as well as the unaffected individual. For the cancer patient, this information can impact cancer treatment recommendations, particularly now with new drugs being used in women that have specific mutations. They can provide information for surgical decisions. When a woman is facing a decision about breast cancer, should she have a lumpectomy, mastectomy, or bilateral mastectomies? Should there be different, more frequent, or earlier screening recommendations, MRI in these high-risk women? When do we begin it, and how do we sequence it with mammography? They can provide a basis for preventive medications, even in the woman who has not had cancer, so that tamoxifen, raloxifene, and an aromatase inhibitor can be used to lower risk of breast cancer. And it can broaden the discussion for the entire family so that once a mutation is identified in the family, unaffected family members can be tested and then can go through a risk assessment and risk reduction plan. So I would argue that genetic testing for cancer is important and should be primarily done across the spectrum of healthcare providers. Genetic testing has dramatically evolved. In 1994, 1995, BRCA1 and BRCA2 were first identified, and over the last 25 years, a tremendous amount of work has been done to understand how these genes impact and how they can be used and the information that they impart. Importantly, in 2008, the Genetic Information Non-Discrimination Act was passed into law, and that will come to later because it should have given us reassurance about the safety of genetic information, but there's still some gaps, and minority communities are particularly feeling those gaps. In 2013, the landscape changed dramatically. The US Supreme Court ruled that Myriad Genetics, that had held the patent on BRCA1 and 2, could no longer hold the patent on human genes. And that opened the door for other companies to come into the market offering larger panels of tests rather than just BRCA1 and 2, and at a markedly lower cost. This really, more than anything, has changed the landscape of genetics and has broadened the availability of testing by lowering the cost structure. In today's world, we use multi-gene panel testing commonly, but there is still a lot of research ongoing to understand those families that, despite this excellent testing that we have today, still remain uninformed. So we have families that have multiple individuals affected. You've done your state-of-the-art testing and you don't find the mutation, and those families need to be better understood. Research is ongoing looking at gene-environment interactions. Why do some individuals develop cancers young, others older, and others who carry a mutation and don't develop a cancer at all? Understanding the significance of variants of uncertain significance, and particularly how that evolves over time. Understanding the risk of mutations and the potential impact of our risk reduction strategies. And then, as we're going to talk about today, really focusing on understanding barriers to dissemination of this information across the population, but particularly across diverse populations. So in the past, genetic testing was really based only on family history, a number of affected family members and their age at diagnosis, and insurance criteria were quite restricted. Currently, that has broadened tremendously, and that's very positive because it allows many more people to qualify for coverage for testing. Now, the metastatic prostate cancer of any type is appropriate for testing. High-risk early-stage prostate cancer, all pancreas cancer, all ovarian cancer, probably all metastatic breast cancer. And then beyond that, individuals who meet the previous criteria based on family history of multiple cancers or young cancer. So clearly our criteria has broadened, insurance coverage has increased, and this is allowing a really broader use of testing. Until 2013, this slide shows the landscape as we knew it. We had 6 or 7 genes that we knew were related to breast cancer, breast or ovarian cancer. BRCA1 and 2 were the 2 largest genes involved. They still remain the 2 most common genes related to breast cancer, but this was really our limited landscape. Once 2013 evolved, the landscape has changed. On this slide, we are now beginning to aggregate the increasing numbers of genes that are related to breast cancer in different ways. We have a group of genes that have very markedly increased risk: BRCA1, BRCA2, CDH1, which is associated with gastric cancer and lobular breast cancer, PTEN with Cowden syndrome, TP53 with Li-Fraumeni, and STK11. We have a group of genes that are moderate risk, and then we have a larger and evolving group of genes that have increased risk, but whose level of risk is quite modest. So the research that's ongoing is identifying more and more genes, and it's really going to be the task of the research community to begin to understand the impact of risk and what needs to be done once a gene abnormality is identified. This slide talks about the clinical management of BRCA mutation positive patients, but it actually could be the management of any mutation positive patient, because once you know that an individual has a mutation, whether it's BRCA1 or 2, ATM, check, you then have the opportunity to test other family members. First degree relatives have a 50% risk of carrying the same mutation. And for the individual in front of you, we can then develop a plan that involves increased surveillance, and it may be increased surveillance for breast cancer, or it may also need to consider, as in BRCA2, ovarian cancer, pancreas cancer, and melanoma. We can talk about preventive strategies such as the chemopreventive drugs that are available. We can talk about prophylactic surgical removal of the breast or of the ovary. In Lynch syndrome genes, there's actually also uterine risk that is quite significant. So we talk about prophylactic surgical removal of the uterus and ovaries. And then there's a whole and evolving discussion about lifestyle change and how exercise may be protective, how alcohol may increase risk, and what other things can an individual do to modify risk. So I believe that the clinical management of the cancer patient, the clinical management of the unaffected but positive mutation carrier can be significantly impacted with this information. Unfortunately, Black populations have remained, and other underserved populations have remained relatively not affected by this information. It's been limited in terms of how widespread this has been. Multiple barriers to receiving genetic counseling and testing have been identified in the literature, and I'm going to show you several slides looking at that. And this is problematic for the population that we're talking about, but it's also problematic for the larger research community. The lack of sufficient diversity in genetic testing participation really perpetuates difficulties for individuals of minority populations who then undergo genetic testing, because the information available to them, the risks imparted by those mutations, the significance of variants of uncertain significance is much less clear than it is in your Caucasian population. So again, the underutilization of genetic testing and counseling leads to limitations on the validity or the usefulness of the information that is derived. Several studies that are highlighted here have looked at barriers to genetic counseling and testing for minority populations, and I'm going to cluster them into 6 categories. Probably first and very important is lack of referral recommendation by the primary care team or by the specialist that an individual is at increased risk and should have genetic testing. Black women are less likely to be referred for genetic counseling and testing than white women, and often that lack of referral, that lack of time spent on education regarding the value of genetic testing is one of the key barriers. Cost of genetic testing has significantly decreased in recent years with the advent of the multi-gene panels, but it continues to affect minority populations' lack of insurance. The financial burden of a cancer diagnosis may also limit the additional ability to pursue genetic testing. So these are barriers that we want at all costs to avoid. It's not so much self-motivation as education. Individuals need to understand the utility of a test so that they can decide that it is pertinent and valuable to them. And it is there that healthcare providers play a significant role in educating patients and educating them about not just the availability of testing, but the value of testing and how it can have implications for them. Some people are unaware that testing is available for more than determining ancestry. They see the advertisements on television with regards to ancestry, but they are not fully aware of the value of this testing when it comes to the healthcare scenarios. The emotional impact of these results cannot be underestimated. Genetic testing can result in strong feelings such as fear, guilt, shame, or anger, and we need to prepare patients for that information. But again, addressing it up front can get rid of that as one of the barriers. It clearly results in an impact to the entire family and can also cause conflicts among family members. So this emotional impact has been reported as a barrier keeping individuals from pursuing testing. Again, we come back to genetic information and the safety of that information. People tend to worry as to how these results will be used and how they will impact their care for cancer, as well as their future employment, insurance, with regards to life and disability, etc. Although we can inform people that the GINA Act is protective, there's still a certain amount of uncertainty as this legislation has not been extensively tested. But again, informing individuals about the safeguards that are in place are important to try to diffuse some of the fear regarding confidentiality and such. And then I think very important is the mistrust of physicians and the medical system. This is something that's pervasive in the healthcare system, but patients may have experienced poor encounters in the past with providers that may have left them cautious as to whether they should trust the recommendations and whether they should trust the healthcare team. Issues such as Tuskegee cannot be forgotten. They have left an indelible mark on the mind and experience of an entire population. And this is actually often cited as one of the barriers that keep people from pursuing genetic information and the potential use or misuse of that information. In addition to just looking at the African American barriers, differences really exist amongst all minority groups, and barriers are different amongst the various minority groups and their participation in genetic testing. In a lovely piece of work by Glenn et al., they looked at the importance of understanding barriers across the various minority communities and even amongst subgroups within those communities. And I think that's very important because communities are not homogeneous. but quite diverse in and of themselves. In Latina women, they commented on the fact that women feel that genetic testing, pursuing genetic information, may compromise the traditional female role of prioritizing the family. By focusing on herself and her risk, it may dilute her role in the family. In Asian women, Chinese, Korean, Filipino, South Asian origin, they commented on the reluctance to hear about negative events in their own future, negative karma and negative future potential. In the African American women, a lack of trust in how the genetic information would be used. Again, looking back at the history of discrimination in that particular population. So the message here is that barriers exist across all minority populations, and a lot more work is needed for us to understand them, but we shouldn't just focus on African American, Hispanic, Asian, really need to dig into some of the subgroups thereof. I want to highlight BRCA1 and 2 because those are the genes that we have the most information about, but germline mutations in BRCA1 and 2 are estimated to occur in 1 to 400 or 1 to 800 in the general population in the United States. The likelihood of familial, harmful, or pathogenic mutation increases as there are individuals in a family with multiple cancers, young age and onset, or other cancers such as breast and ovarian cancer. Below on this slide are the estimates of carrying a pathogenic mutation based on groups. And as you can see in the Ashkenazi Jewish community, the likelihood is the greatest of any other group, with about 12% of the population carrying, having a potential for this gene. The risk is 1 in 40, but if you have a cancer diagnosis, a breast cancer diagnosis, up to 12% of women will carry a BRCA1 or 2 mutation versus the 1 in 40 that we see in the general Jewish community. If you have a breast cancer diagnosis, non-Ashkenazi white, about a 3% likelihood of carrying a BRCA1 and 2 mutation, Asian 0.5%, African American somewhere around 4% when you include BRCA1 and 2, and Hispanic about 3.5%. Now, this is just for BRCA1 and 2. We haven't looked at the other genes in the multi-gene panels and how much they contribute to that, but there clearly is variation in the frequency of these mutations amongst the different ethnic groups. Variants of uncertain significance are particularly problematic. It's a result that is neither positive nor negative. It's a result where the laboratory is unsure if this variant would predispose an individual to a health condition or whether it's an insignificant variation that leads to nothing. Over time, as labs test more and more people and more of these variants are identified and more information is collected, these variants are often reclassified. Rarely they're reclassified as pathogenic or harmful. More often they're classified as normal variants in the population. And sometimes there is not enough information and they remain as this bucket of variants of uncertain significance. Due to the lack of genetic data on non-European or Ashkenazi Jewish ethnicities, minority populations are much more likely to have a variant of uncertain significance after multi-gene panel testing. And unfortunately, these results are typically treated as negatives until laboratories reclassify them, but carrying variants leaves patients with some uncertainty as to what their risk really is and leaves families unable to move forward further with additional testing because we don't have a real understanding as to whether we're dealing with a disease-related abnormality or a variant of no real significance. On this slide are the rates amongst hereditary cancer multi-gene panels, looking at the small panels, which are 3 to 9 genes, the cancer-specific breast, colorectal, or prostate panels, which are 12 to 26 genes, or the larger panels, which are 20 to 40 gene panels that are the common cancer panels. And the various colors represent the various ethnic groups. The theme from this slide are that as your testing goes from a small number of genes to a larger number of genes, the frequency of finding variants of uncertain significance increases quite dramatically to about 40% of African American individuals tested for a common panel. The second theme of this slide is, again, if you look at the African American and the Asian communities, followed by Middle Eastern communities, much more likelihood of finding variants of uncertain significance than you would have in the Ashkenazi Jewish community, which has the lowest risk, or the European community, which has a 20% risk. And that is purely a function of the number of people that have undergone testing within those communities, so that variants can be reclassified as non-significant. So this is just to demonstrate that participation in genetic research can have significant impacts on this variant reclassification. Highlighting triple negative breast cancer, because this is an entity that is significantly important in the African American community. Triple negative breast cancer is a cancer that is estrogen, progesterone, or HER2 negative, although we could go into a much more fine-tuned discussion about genetic changes in triple negative disease and some of the new tools that we have that can subdivide this into basal and other types. Triple negative breast cancer is more common in Black women than it is in white women. Diagnosed under 60 years of age with no family history is actually one of the criteria currently for genetic testing, because we know that the likelihood of finding genetic abnormalities in triple negative breast cancer is much higher. There is a West African founder mutation in BRCA1 that is associated with triple negative breast cancer. And a study by Rummel et al. Showed a higher percent of BRCA1 mutations found in triple negative breast cancer of Black women than in white women, and particularly so in younger African American women. So triple negative breast cancer is getting a lot of attention in terms of finding new therapeutic interventions, but in the area of genetics, the role of genetic testing is very important. The genetic testing and counseling process is a multi-step process, and it's really critical that these steps are taken so that in diverse communities, we make sure that the information is disseminated well, that the information is understood well, and that the implications are understood before testing is done. And this is where genetic counselors play a great role. Genetic information is going to have impact on the psychological status of the patient, so we need to prepare for that. It's going to affect the family, so discussing family communication is important. But in that genetic counseling process, we need to discuss the risk that we may be dealing with various mutations. We need to make patients aware of the potential impact on employment and insurance to dissuade some of the fears, but to fully educate. And we need to be able to offer education and support. So genetic counseling needs to be made available to all communities, and the level of support is important. One of the barriers to genetic testing and counseling may potentially be the services that are available in the community. The population of individuals providing genetic counseling services is not a largely diverse population. That's for genetic counselors, but I would say for physicians in general who are involved in the cancer genetics work. In 2020, a professional status survey from the National Society of Genetic Counselors showed that 90% of genetic counselors self-identify as white or Caucasian, and only 2% reported being Black or African American. So again, we need to really focus on enhancing the pathway into the medical profession so that patients see providers of their own like providing these services, and therefore may be more receptive. So to end on a positive note, I just wanted to highlight some examples of strategies to increase minority participation in genetic testing and research that have been successful. So we know this is important. We know education is important. We know that providing services in a way that's comfortable and informative is important. So what have people done? Anton Culver et al. Did some interesting work looking at specialized literature focused on minority groups, and they were able to show that you can enhance the participation of minority groups in genetics research when you do this focused educational and informational material. Community-based partnerships have been shown to be important. Community-engaged and community-driven health promotion programs have been shown by Campbell, Corby Smith et al., and Israel to be positive and impactful. And faith-based organizations can be used. Lumpkins et al. Has a nice article of a pilot that was launched in a faith-based organization to, number one, address and understand the barriers to participation, but number two, begin to think about ways to reach that community in a positive way. So I think the future is exciting, and although there are many barriers at play, there are things that have been done to address these barriers, and a lot more work is needed that is being done. So with that, I want to thank you for giving me time to speak with you, and I've enclosed some references that may be of helpful to you. Thank you very much.